Hello guys, I am Vishnu and today I am back with part 2 video of antipsychotics. So yesterday we saw the first part, as I said before in the previous video, that we will be dividing this into two sections. So in the part 1 video, we saw about the dopamine hypothesis. What is the connection of dopamine with schizophrenia? What is the connection of serotonin with schizophrenia? How we started making first generation and second generation antipsychotics. What is the correlation of antipsychotic potency with ADR? That means, like as I said to you, that first generation antipsychotics are classified into two. One is high potency antipsychotics and the other is low potency antipsychotics. Then we had the receptor pharmacology. That means there are different receptors. There are different serotonin receptors. There are noradrenaline receptors. Some receptors I had mentioned. So what will happen if that receptor is activated or if that receptor is blocked? And then a small flowchart regarding the treatment guideline for schizophrenia. So these were the things that we discussed. Once again, we discussed about the dopamine hypothesis. We discussed about the serotonin hypothesis. We correlated the potency of antipsychotics with ADR. How can we predict the ADRs? Then we talked about the receptor pharmacology. And then we talked about the treatment guideline for schizophrenia. So today I will be talking to you about the side effects of antipsychotics. So first we will come to the major problem that comes with antipsychotics, and that is dopamine receptor blockage. So whenever, especially as I said, D2 and D3 receptors are mainly involved in producing dopamine, especially D2. So definitely whenever D2 receptors are blocked, it usually causes extrapyramidal side effects. So always remember, you may have heard of a disease known as Parkinson's disease, in which low levels of dopamine are observed. So if antipsychotics block D2 receptors, there is a chance of symptoms, or there are chances of side effects which mimic Parkinson's disease. And there are other symptoms also that may be seen. So whenever the D2 receptor is blocked, situations like EPS can occur, that is extrapyramidal side effects. Typical antipsychotics cause more extrapyramidal side effects than atypical ones. The maximum extrapyramidal side effects are caused by high potency drugs. So when we talked about the previous slide, the correlation of potency with ADRs, we said that high potency antipsychotics have more affinity towards D2 receptor. So as a result of which it can cause extrapyramidal syndrome. And the low risk of extrapyramidal symptoms are seen with low potency antipsychotics. If we talk about atypical antipsychotics, aripiprazole has the lowest risk of EPS. Because as I said to you yesterday, that aripiprazole, brexpiprazole, they have a peculiarity. They are known as serotonin, dopamine activity modulators. That means they neither allow it to rise too much and they neither allow it to reduce too much. So the risk of extrapyramidal syndrome will be less with aripiprazole, which is followed by ziprasidone. Among atypical antipsychotics, risperidone has the highest risk of extrapyramidal syndrome. And here there is something interesting that I would like to talk about. We will come to that later. So actually, when we talk about the side effect of risperidone, it is actually a dose-dependent effect. Like I personally believe that we cannot remember the doses of every medicine depending on every condition. For example, if a particular medicine's dose is 6 mg, now when that the patient who is taking it, if it is a pediatric, the dose will change. If it is a geriatric, the dose will change. If the patient is having kidney disease, the dose may change. If the patient is having hepatic dysfunction, the dose may change. So we cannot remember all of these doses for all the medications. I personally believe that the best way to remember doses through clinical practice. When you are dealing with those medicines in clinical scenarios, for example, you are going for rounds, you are going for hospital duties, or you are personally dealing with those medications, then you develop a habit to remember the doses. So risperidone has a dose-dependent effect. This is also another way to remember doses of medicines. Dose-dependent effect means at a particular dose, it shows a particular action. So it can be a positive action or it can be a negative action. So if the dose exceeds 6 milligram per day, I'm talking about risperidone. If the dose exceeds 6 milligram per day, there is a risk of extrapyramidal symptoms. And that is why the dose should always be below 6 milligram per day for maximum beneficial effects and minimum risk of side effects. Aripiprazole has lowest risk of extrapyramidal symptoms due to partial agonism at D2 receptors. Partial agonism means 50% it has a blocking tendency, but 50% it shows agonistic activity also. So that is why it may cause D2 related side effects. That means it can cause side effects which is related to dopamine activation. So we will talk about that later. So when we come to the D2 block side effects, there are some technical terms which come under extrapyramidal symptoms. The first term that comes is acute dystonia. So this is the earliest sign of extrapyramidal symptoms. Dystonia means it is a spasm of head, neck, tongue, and laryngeal muscle. So spasm means contraction. So you will feel a kind of stiffness. So this kind of people will have difficulty in speaking because you will have tongue spasm. You may have difficulty in breathing also because of laryngeal spasm. So this is usually seen in younger patients. So dystonia means spasm of most of the voluntary muscles. And then we have Parkinsonism. Parkinsonism, you know very well, it is a condition which is associated with low dopamine levels in the CNS. So that can cause a perioral tremor also. It is also known as rabbit syndrome, perioral tremor. And it is usually seen in elderly because the elderly are much more prone to Parkinson-related side effects or Parkinson's disease. So when we come to the treatment of acute dystonia or Parkinsonism, if it is a life-threatening condition, like it is an acute crisis, we usually use antihistaminics, which have maximum anticholinergic properties also. Because always remember, acetylcholine causes Parkinsonism, and acetylcholine is the enemy of dopamine. Dopamine and acetylcholine are enemies. And that is why in drug-induced Parkinsonism, we use anticholinergics. So if we are having acute crisis, acute severe dystonia or severe Parkinson-related problems, then we can use antihistamines that have anticholinergic property. So for example, we can use promethazine, we can use diphenhydramine. And once the acute crisis has been resolved, and if you want to maintain the patient to prevent this thing from again happening, like for example, if you want to prevent acute dystonia from happening again or Parkinson related problems to happen again, so for long-term maintenance, we can use anticholinergics. So it can be trihexyphenidyl, it can be benztropine, it can be biperidine. Always remember, there is a very special thing that I want to tell about anticholinergics. Anticholinergics should not be used in elderly unless and until it is very urgent, because anticholinergics usually cause memory loss. Anticholinergics are associated with memory loss or dementia. So it is not a good option for elderly patients, because as your age increases, there is always a risk of memory loss, dementia, and even Alzheimer's disease also. So if a patient is having Alzheimer's disease, anticholinergics is not at all a good option. Now we come to the next extrapyramidal symptom, and that is akathisia. This is the most common extrapyramidal symptom. So this is a condition in which the person has a irresistible tendency to move around. So means if they start moving, they will keep on moving and they will not stop. Even if there is a wall in the front also, they will not stop. So that means they will be completely restless. And if that person is a smoker, it can be a chain smoker or a person smokes a lot of cigarettes or packs in a particular day. So in that condition, this restlessness can get aggravated. So in that condition, the treatment is beta blockers. We usually give propranolol, that is a drug of choice. It is a lipophilic beta blocker, so it can cross the blood-brain barrier also. And we can give benzodiazepines. The reason for giving benzodiazepine is you are having an irresistible tendency to move around. That means your muscles are getting involved, your entire body is moving. And that means the cerebellum is getting involved abnormally. So if we are giving benzodiazepines, it will calm the CNS, and as a result, the abnormal tendency, abnormal movements will get reduced. The next side effect is tardive dyskinesia. So this is actually also known as anything that you are doing repetitively. For example, if you are moving your face to the left side, you are constantly moving to the left side. Or if you are moving your face once in the left and then in the right, you are doing it repetitively without stopping. So it can be repetitive blinking, it can be lip smacking. So it is a stereotype repetitive movements of facial, neck, arm, and leg muscles. So this is usually seen in elderly. So usually we give, if tardive dyskinesia is happening, so this usually happens due to first generation antipsychotics. So if it is happening due to first generation antipsychotics, then we can switch over to atypical antipsychotics. But again, we should be careful. Risperidone has a risk of causing this problem. So we should be careful when we are switching over to atypical. We can switch over to some other molecule also under atypical if it is required. And for tardive dyskinesia, we can use VMAT2 inhibitors also. Vesicular monoamine transporter type 2. These are some new molecules which are actually approved for tardive dyskinesia. It is valbenazine and deutetrabenazine. Actually, these are the drug of choice. But if the tardive dyskinesia is happening due to first generation antipsychotics, we can switch over to second generation. And the last, which is the most dangerous extrapyramidal symptom, that is neuroleptic malignant syndrome. This is life-threatening. In this condition, you can have rhabdomyolysis, you can have muscle damage, muscle rigidity. Creatine phosphokinase level can increase. It can cause hypotension and hypothermia. So this condition is quite dangerous. So especially, actually hypothermia is also observed in some, but in majority of conditions, hyperthermia happens. And it is also known as malignant hyperthermia in some conditions. So if those conditions happen, then the drug of choice is dantrolene sodium. Dantrolene sodium is the drug of choice. We can use dopamine agonist also, because this is happening due to dopamine blockade. So we can use dopamine agonist also. For example, bromocriptine. Now we come to the side effects when other receptors are blocked. Till now we were talking about dopamine blockade. Now we will talk about other receptors. So as you know very well that if H1 receptor is blocked, it can cause sedation and weight gain, as I mentioned in the previous video. If muscarinic receptors are blocked, always remember acetylcholine increases the secretions of your body. Whether it is your saliva, whether it is your tears, whether it is urine, whatever it is, acetylcholine increases sweat production also. So when acetylcholine is blocked, all these secretions will get blocked. So you can have dry mouth, you can have sedation, you can have constipation, you can have urinary retention, which in long time can lead to urinary tract infection. You will not be able to produce sweat, so you can have fever because toxins get accumulated. So all this kind of problems can happen. Serotonin and histamine, they usually act on hypothalamus and they usually cause anorexia. So if you are blocking serotonin and histamine, the opposite will happen. So your appetite will increase and it can cause weight gain also. Molindone is the only antipsychotic that has been proven to cause weight loss. Although this is not a very common molecule here, this is just for your practical knowledge. Molindone is the only antipsychotic that causes weight loss. When we talk about atypical antipsychotics, maximum obesity is seen with clozapine followed by olanzapine. So clozapine has the highest risk of obesity, which is followed by olanzapine. And among atypical antipsychotics, the least risk of obesity is seen with aripiprazole, which is followed by ziprasidone. So aripiprazole is favorable for this condition also. It has the least risk of obesity. If alpha-1 receptors are blocked, as I said before in the previous video, if alpha-1 receptors are blocked, sexual dysfunction can happen. If alpha-1 receptors are blocked, noradrenaline levels reduce. So as a result, it can cause dilation of arteries and veins, which can lead to postural hypotension. Quetiapine actually blocks alpha-2 receptors. So please understand that alpha-1 and alpha-2 have opposite actions. Alpha-1 receptor increases noradrenaline. Alpha-2 receptors reduce noradrenaline. So if quetiapine is blocking alpha-2, that means noradrenaline will increase. So it can lead to hypertension. Antipsychotics usually can also cause insulin resistance, diabetes, new onset diabetes mellitus, and also abnormalities with your cholesterol levels. Antipsychotics can cause insulin resistance, which can increase the risk of diabetes. So always remember that if dopamine level reduces too much, that can cause insulin resistance. And that is why you may have studied in the classification of antidiabetics, we give dopamine agonist, although it is not commonly used, but we give dopamine agonist, for example, bromocriptine. And antipsychotics, when they cause insulin resistance, that increases lipolysis and it can increase your triglyceride levels. So it can cause hypertriglyceridemia. So that again increases the risk of obesity and dyslipidemia and all this kind of problems. The maximum risk of diabetes and hyperlipidemia is seen with low potency first generation antipsychotics, clozapine and olanzapine. The least risk of diabetes or insulin resistance or hyperlipidemia is seen with high potency first generation drugs. For example, haloperidol, flufenazine, etc., aripiprazole, acinapine, cariprazine, and ziprasidone. This is very, very interesting. Actually, I was just checking a particular MCQ. So in that, this question had come in a different manner. High potency antipsychotics can cause hyperprolactinemia. So always remember that prolactin and dopamine are enemies. So as I said before that acetylcholine and dopamine are enemies. Now I'm coming with another term. Prolactin and dopamine are enemies. So if prolactin level increases, it indicates that dopamine levels are low and vice versa. So high potency antipsychotics can cause hyperprolactinemia, which is maximum with haloperidol because it has the highest potency to block dopamine receptor. Among atypical antipsychotics, the highest risk is seen with risperidone and paliperidone. Aripiprazole, brexpiprazole, and cariprazine, they have partial D2 agonism. As I said before, they are partial D2 agonist. So they can cause hypoprolactinemia. So this is something that you need to understand. If D2 receptors are completely blocked by high potency drugs, then hyperprolactinemia can happen. And if there is a partial agonism of D2 receptors, or if D2 receptors are activated by any other molecule, then it can cause hypoprolactinemia. QT interval prolongation is also seen. So the reason is that antipsychotics usually block cardiac potassium channels. So as a result of which, there is a risk of QT interval prolongation that can lead to life-threatening condition known as torsedous D points. So the highest risk is seen with typical antipsychotics, ziprasidone, which is having a very high risk, quetiapine, and serpindole. Coming to miscellaneous side effects, let's come to clozapine, which is one of the most dangerous medicines. This drug blocks D4 receptors. So as I said in yesterday's video, that we have 5 types of dopamine receptors, D1, D2, D3, D4, and D5. Clozapine has activity on D4 receptors. So that can cause seizures. So if the D4 receptors are blocked, it can cause seizures. So these are some of the practical knowledge that you can gain from this thing. You can note it down also. If D4 receptors are blocked, it can cause seizures. This drug increases the level of eosinophils. I hope you know what eosinophils are. Eosinophils are a part of granulocytes. We have neutrophils, basophils, and eosinophils. So this drug can increase the level of eosinophils, and it increases the level of immunoglobulin E. So when eosinophils increases too much, immunoglobulin E also increases. So that can lead to myocarditis. So you can derive 2 practical catch points from this. Number 1, if a patient is having severe heart disease, clozapine is not a good choice. And if a patient is suffering from severe asthma, which is related to hypereosinophilia, because when eosinophils increases, it also increases the risk of asthma. So when clozapine increases eosinophils, it may not be a good option for severe asthmatic patients also. This drug can cause agranulocytosis, which has a high risk of sepsis. So it is a bit contrasting because it increases eosinophils, but it can cause agranulocytosis also. So here the meaning of agranulocytosis is it reduces the level of neutrophils. And that is why CBC monitoring is mandatory for patients who are under clozapine therapy. CBC means complete blood count. And why will there be a high risk of sepsis? Because neutrophils get reduced. And neutrophils are an important line of defense of our body. If neutrophils get reduced, then definitely there is a high risk of sepsis or infections. If clozapine is used with carbamazepine, CBZ is carbamazepine, there is a high risk of agranulocytosis because carbamazepine also causes the same. So that is a contraindicated drug interaction. Clozapine has also been shown to cause anticholinergic effects. So that has the highest risk of constipation. Clozapine has the highest risk of constipation. Clozapine stimulates M4 receptors. Muscarinic receptors, I hope you know, there are 5 types of muscarinic receptors, M1, M2, M3, M4, and M5. Clozapine stimulates M4 receptors, which leads to the blockade of M3 receptor. And as a result, you will have increased saliva production. So this condition is known as wet pillow syndrome. Once again, clozapine blocks M4 receptor. Clozapine activates M4 receptors, which ultimately blocks M3 receptor, leading to increased saliva production. So this is also known as wet pillow syndrome. But again, clozapine is the last choice. If all the antipsychotics do not respond, then clozapine is the last choice. And this is also the only antipsychotic which has potential to be used in patients who are having suicidal tendencies also. So in schizophrenia, if a patient is having suicidal tendencies also, clozapine has shown to provide benefits. When we come to other miscellaneous side effects, thioridazine is a low potency first generation antipsychotic. It can cause retinal deposits, which can make your vision brownish. So it can cause browning of vision. And when we come to chlorpromazine, CPZ, it can cause photosensitivity because chlorpromazine has a tendency to absorb UV rays. It is like doxycycline, it is like tetracyclines. This molecule also has a tendency of absorbing UV rays. So that is why patients on chlorpromazine are always advised to wear any kind of sunscreen or some kind of protective clothing or something like that, so that the risk of sunburns can be reduced. It can cause retinopathy also. So if a patient is having blurred vision after taking after taking chlorpromazine, they should report to the physician or the pharmacist. And it can cause the deposition of melanin in the lens. So it is also known as retinitis pigmentosa. So this is a problem seen with chlorpromazine. When we come to pregnancy, haloperidol is the safest antipsychotic and olanzapine is the most unsafe antipsychotic. So this is just for your information purpose. So we have finished with the side effects of antipsychotics. Now we come to the route of administration. So most of the antipsychotics are given orally. Penfluridol is the longest acting oral antipsychotic. So it can be given once a week. That is the power of penfluridol. It is the longest acting oral antipsychotic. Haloperidol in IV formulation is given for the acute management of psychotic episode, although it is off-label use, but still it may be used. Intramuscular depot formulations are long-acting and they are given for non-compliant patients. Actually, the problem with schizophrenia is not just the disease. As I told you, in schizophrenia, delusions, hallucinations, all these things happen. So this kind of patients will never accept the reality that they are suffering from a particular disease. And that is why when medicines are given to them, they have a tendency to throw away those medicines. They have a tendency to not use those medicines. So that can again worsen the disease. So in that condition, we give long-acting formulations to these patients, like maybe once in 14 days or once in 28 days, or maybe once in a month or something, which can act throughout the duration. So this is usually given to non-compliant patients. So examples are haloperidol. Haloperidol is the longest acting injectable antipsychotic, which can be given once a month. So it is a long-acting injection, haloperidol decanoate. Loxapine is actually given intranasally for agitation. So this is a new formulation. Loxapine can be given intranasally. Acinapine has high first pass metabolism, almost 98%. So if we are using it orally, that does not make any big of a sense, because 98% first pass metabolism means the plasma drug concentration will be tremendously low. So that is why it is given as orally disintegrating tablets, or it is given sublingual. So again, we can understand one thing is acinapine is given in severe or acute conditions, because orally disintegrating tablets and sublingual tablets are only given in acute conditions. Let it be any condition, it is given in acute or acute severe conditions. So these are some of the typical and atypical antipsychotics which can be given intramuscular for long-term management and emergency management. So if we come to intramuscular antipsychotics for emergency department, for typical antipsychotics, we can give chlorpromazine, trifluoperazine, perfenazine, flufenazine, loxapine, and haloperidol. And atypical antipsychotics, we can give aripiprazole, olanzapine, and ziprasidone. When it comes to long-term management, in typical antipsychotics, we can give flufenazine decanoate, haloperidol decanoate, and among atypical antipsychotics, we can give paliperidone palmitate and risperidone long-acting injection. Now we come to what is new about, what are the new trends in technology, or what are the new things that are coming up regarding antipsychotics. So we come to the third hypothesis, and that is known as the glutamate hypothesis. Glutamate and dopamine are known to be enemies. So when glutamate increases, dopamine reduces. And when glutamate reduces, dopamine increases. So accordingly, you can understand the positive and negative symptoms. Because if dopamine increases, positive symptoms. And if dopamine reduces, negative symptoms. So glutamate is an excitatory neurotransmitter. So it may cause psychosis on its own also. So there are some glutamate antagonists which are currently under development. They are going through clinical trials. There is an amino acid known as glycine, and glycine is the best friend of glutamate because glycine binds with glutamate and then it goes to NMDA receptor, which can cause psychosis. NMDA is N-methyl D-aspartate. You may have heard of this receptor somewhere else. It is in Parkinson's disease. So glycine is required along with glutamate. And when these two combine together, they can increase the risk of psychosis. So if the glycine production is blocked, it may have antipsychotic effects. And that is why there are some molecules which are currently under clinical trials. One is betopertin and the other is sarcosin. So these are glycine transporter 1 receptor inhibitors. That means they reduce the production of glycine. So these are currently under clinical trials. Let's hope we can get this molecule soon and we'll get more information about what happened regarding this. If you get any information, do share with us. And there is a new medicine that is pimavanserin. So this was also a recently approved atypical antipsychotic. This is actually indicated for hallucination and delusions associated with Parkinson's disease. This is actually an inverse agonist at 5-HT2A receptors. So this is regarding pimavanserin. So pimavanserin is actually used in conditions where you are having hallucinations or delusions due to Parkinson's disease. So in Parkinson's disease, you will develop hallucination and delusion because of the medicines that you use for Parkinsonism. So long-term usage can increase dopamine level and that can lead to hallucination or delusion. So we use pimavanserin for the same. And then there is a molecule known as samidorphan. Samidorphan is an opioid antagonist. So when we use olanzapine in patients, there is a risk of weight gain. So clozapine has the highest risk of weight gain, which is followed by olanzapine. So samidorphan is used in combination with olanzapine to reduce the risk of weight gain due to olanzapine. Now we come to the uses of antipsychotics. Atypical antipsychotics are more preferred, as I showed you in the guideline before. If you want initial treatment, we usually prefer drugs with lesser metabolic side effects. For example, aripiprazole and ziprasidone. Obviously, ziprasidone, if you are using, you have to be careful if that patient is having cardiac conduction problems because it has the highest risk of QT prolongation. Only if atypical antipsychotics are ineffective, you should go for typical ones. Clozapine should be used only in the last stage. It is a reserve molecule. It should only be used in refractory schizophrenia and suicidal tendencies. Typical neuroleptics are more effective against positive symptoms because typical antipsychotics block dopamine receptors. And when dopamine increases, as I said, it causes positive symptoms. Atypical neuroleptics or antipsychotics are more effective against both positive and negative symptoms. Acinapine is the most effective in the treatment of negative symptoms. So as I said before, acinapine has a problem. It has a high first-pass metabolism. So it has to be given as an orally disintegrating tablet or sublingual. Lurasidone is used in acute decompensated schizophrenia. So when we acute decompensated means that it refers to symptoms of schizophrenia which has become very severe. So this is a kind of schizophrenia in which the symptoms have become very severe, and you can understand it from the name itself. It is written acute. So anything that is acute means it is severe. Antipsychotics are also used in depression. So aripiprazole, olanzapine, and risperidone, they are used as add-on therapy. Add-on therapy means they are not used as a singular agent. They are used with antidepressants for the treatment of resistant depression. Resistant depression means it is a condition in which most of the antidepressants are not working. Quetiapine is the only atypical antipsychotic which can be given as monotherapy for depression. The reason is when quetiapine enters into your body, it is metabolized to norquetiapine. And this norquetiapine has a tendency to block norepinephrine reuptake. That means it increases norepinephrine levels. So when I taught you the receptor pharmacology, I said that noradrenaline, when it increases, it reduces depression. So that is why quetiapine is the only atypical antipsychotic which is effective as monotherapy in depression. It can also be used in mania and bipolar disorder. I hope you know what it is. Mania is extreme elevations of mood, and bipolar is you are completely in a roller coaster between extremely high mood and extremely low mood. That means you are going into psychosis also, and you are going into depression also at the same time, or on alternate times. So antipsychotics are fast-acting anti-maniac drugs. So they are used in acute mania. They are also used in bipolar disorder. Atypical antipsychotics are more preferred than typical antipsychotics. Then we come to a condition known as Huntington's disease and also known as Huntington's chorea. So as you can see from the image, this is actually a girl who is having Huntington's disease. And if you look at the picture, you can understand that this person is actually having abnormal jerky movements. So Huntington's disease is a condition in which you are having abnormal jerky movements, and those abnormal jerky movements are known as chorea, C-H-O-R-E-A. So the drug of choice is valbenazine, deutetrabenazine, which are VMAT2 inhibitors. The second line choice is atypical antipsychotics, and the third line choice is typical antipsychotics. So this is actually a French neurologist who discovered tic disorders. So his name is Georges Gillet de la Tourette. So tic disorders are named after him. It is also known as Gillet de la Tourette syndrome, or in simple words, Tourette syndrome. So it is a psychiatric disorder which is characterized by motor tics and vocal tics. So motor tics and vocal tics means whatever you are doing it repetitively. So, and it happens very suddenly, it happens unpredictably. So motor tics means sudden uncontrollable movements. For example, eye blinking, grimacing, head jerking, or shoulder shrugging, and you are doing it repeatedly. Vocal tics means, for example, you are clearing your throat, you are making a voice as if you are clearing your throat, and you are doing it repeatedly. So usually clonidine is used. Clonidine is the drug of choice for Gillet de la Tourette syndrome because it is an alpha-2 agonist, which has been found to be good for reducing tic disorders. Atypical antipsychotics are the second line choice. And due to any medication, if you are developing tic disorders, or due to any drug abuse, if you are developing tic disorders very severely, then you can also go for haloperidol. So that is the third line choice. Autism associated irritability. So the medicines, antipsychotics do not directly reverse autism because autism is almost incurable. But what happens in autism is that it happens at a very young age, and the children who are having autism, they lack sociability. They don't like to interact. Like if it is a baby or a child, they usually have a playful attitude. They usually play, they move around, they roam around. But a child with autism will always prefer to be isolated alone. And that is why their performance in school will also be very poor. Their academic performance will be very poor. And this kind of patients will have very severe irritability. That means aggressive nature also. So to reduce that aggressive nature or irritability, we can use risperidone and aripiprazole. So they are indicated for aggressive behavior associated with autism. Please remember, they do not cure autism. They only manage the behavioral manifestations that happen due to autism. It can also be given for MSs, that means vomiting conditions, because as you know, dopamine, whenever dopamine increases in your body, it increases a tendency to vomit, because dopamine activates the chemoreceptor trigger zone, CTZ. So all typical antipsychotics except thioridazine are used as antiemetics. So promethazine can also be used as an antiemetic. So promethazine has another peculiarity also. For example, if you are going for long distance bus journey, there are people who have tendency to vomit. And if they are going for long distance journey, like more than 12 hours, 13 hours or 14 hours or something, they may not have a proper sleep also. And along with that, due to the jerking of the bus movements, they may have vomiting tendency. So promethazine is actually good for those kind of people, because promethazine has two properties. Number one, it is a dopamine blocker, so the tendency to vomit will be very low. And number two, it is a histamine antagonist, H1 receptor blocker also. So that will be good for producing sleep when you are traveling for long distances. So if you are traveling for long distances and at the same time you don't want to vomit, means you have a problem of motion sickness, in that condition, promethazine may be a good choice. Antipruritic activity has also been seen. As I said sometime before, histamine causes pruritus. So promethazine or any kind of antipsychotic which has H1 blocking property, that can be used as antipruritic agents. Low potency phenothiazines have H1 blocking effect, so they may be used as antipruritic agents. However, we do not use them in clinical practice because pruritus is very inferior in compared to the side effects that is produced by these medicines. So we have very better alternatives which we can give. It is also an off-label use actually. It can be given for insomnia. The reason is that quetiapine has 5-HT2A receptor blockade activity, which can cause sedation, and it has H1 blockade tendency also. So from this, you can derive a practical knowledge that it blocks H1 receptor, so it can cause sedation as a side effect, and it can also cause weight gain as a side effect, because H1 receptors are blocked. It is not FDA approved, but in some clinics, in some areas, it is used as off-label purpose. In very severe hiccups, always remember dopamine, when dopamine levels are too high, it can cause hiccups, which will not be easily relieved. So if you are having very severe hiccups, whether it is a pediatric or whether it is any age, in severe hiccups, we can give chlorpromazine. It is the drug of choice for intractable hiccups. Intractable hiccups means severe hiccups which is not resolving. So we come to the last part of the presentation. To remember the uses of antipsychotics, you can try the code antipsychotic. So this is actually, I referred it from a book. This was very interesting. I think this can also help you to remember some of the uses. Anti means antiemetic because it has dopamine blocking activity. Psy means psychosis. Co means chorea. So due to Huntington's disease or something like that, Huntington's chorea, we give antipsychotics. And then tic means tic disorders. So Gille-Dira-Tourette syndrome. So for that also we give antipsychotics. So that's it regarding this presentation. I hope that it has been informative for you. it has been productive for you. And definitely there are a lot of things that are under investigation, and a lot of changes, a lot of extra information you will get from books, from your clinical practice, or from the mentors that you are under. So I hope that you have liked this. If you have got some kind of practical knowledge, do like and do share and subscribe. Please share it to maximum people, because our motive is that we want to disseminate practical knowledge and practical visualization to maximum people possible. Thank you so much for viewing.